So we've talked about our types of shock. So now what we're going to do is we're going to look at stages of shock. Okay? So when we look at our stages, our first stage compensated shock. Okay? So we start to recognize this by increase in heart rate, usually an increase in respiratory rate. A lot of times the patient may stay normal tensive, so we don't really see an increase or decrease significantly in their blood pressure. So we kind of say that they're normal tensive. Okay? So here, we have a patient who's been in a motor vehicle accident. We show up and their heart rate is elevated, it's 110. A lot of times we start looking at some of these things and we dismiss them, right? So when we look at the first signs of hypoxia, right, usually it's anxiety, agitation, irritability. So those are the first signs that a patient's starting to become hypoxic, right? They're starting to become irritated because they don't have enough oxygen. And we miss that all the time because we dismiss it and say, well, they're anxious. They were just in a car accident. Of course they'd be anxious. Or they were just in a trauma and they're hurt, so they have pain. Of course, they'd be a little tachycardic. And we miss that these are actually the first signs of the body starting to, overcompensate for other parts that are failing. So we want to be sure that we're always, if we look at something and we have an index of suspicion, right? You show up for a motor vehicle accident and there's a potential that potentially there could be internal bleeding. I'm not going to wait until they show outward signs of being in that decompensated shock, which we're going to talk about. Then if I wait till then, I really reduce the likelihood of a positive outcome for this patient. We want to recognize right away when we're walking towards this accident, based on that mechanism, hey, there's a likelihood that this patient could be badly injured. Let's start treating aggressively and making sure that we prevent them from either going into or progressing through these stages of shock. Okay? So we always want to be aggressive in our management. When we say aggressive, it means we want to be quick acting, not violent in any way. So that's not what we mean by aggressive. We're not doing things more forcefully. We're doing things quicker. We're recognizing that there's a need and we're following through. So we have our compensated shock, and then we see our patient in decompensated shock. So the way we recognize this progression outward in the field is going to be hypotension. Okay? We start to see a drop in the blood pressure. The reason we see a drop in the blood pressure is because in this compensated shock, right, while the heart rate is increasing, the respiratory rate is increasing, this is going to require more energy, more fuel, more glucose. So now the body's going to start, like we talked about, in our types of shock, we looked at all those that have that sympathetic response. One of the other things that happens with that catecholamine release is the body is going to release reserves of glucose into our bloodstream. So now if I need to be able to fight off a lion or run away from them, right, I need extra energy, and they're going to send that to, my large muscles. So now I can run away or I can use them to fight them off. Once we've gone through our reserves, we don't have any more fuel to do this. We need more energy in order to compensate. So it works well for a short period of time, but then we start to create a bigger deficit, right? It's like when you owe money, you borrow from somebody else, and now you owe two people. You might have put a little Band-Aid on it, but it hasn't fixed the underlying problem. And that's what this does. The compensatory mechanism of the body do a good job for a short period of time, but once we run out of that fuel source, we don't have the ability to kind of keep this up. So now what we start to see is, the reason they're normal tensive here is the blood pressure is being driven by this increase in heart rate, right? And by that vasoconstriction. So now we start to see our patient become hypotensive. We're going to see kind of a quick spike in their heart rate, and then there's no way the body's going to be able to maintain that. So then we start to see them, we have that decrease in their heart rate, and they become bradycardic. Right, that bradycardia. So now we know that this patient is in decompensated shock, right? If we are not able to stabilize this patient here, right, as these body systems are starting to tire and starting to fail, multiple systems are going to start to fail. That's where we start to progress and we have our This is death. You can't come back from this. When we get to here, too many body systems have failed, right? As we start to look, as these mechanisms start to fail, this hypotension is going to cause vasodilation, right? So we're no longer able to vasoconstrict, the body's going to vasodilate. They're losing heat very rapidly, which is why our treatment is to keep them warm. They can't thermoregulate. We have to take that over for them. As this starts to happen, the blood is going to start to slow down. They become bradycardic. We're going to start to have that blood start to sit. So we start to talk about in this irreversible shock, we have this kind of like triangle of death, right? The patient's going to start to become acidotic. The patient's going to start to become hypothermic. We start to get that, disseminating intravascular coagulopathy. That's where that blood pools and starts to sit. So, when we talk about our DIC, that disseminating intravascular coagulopathy, that's where now that blood pools, it clots. And now what happens is when blood sits, it becomes gelatinous. So as we have that happening in all of our body systems, now they go into that MODS, multi-organ dysfunction system. They're in system failure. There we go. All right, multi-organ dysfunction system. They're in that multi-system organ failure. All of a sudden now the kidneys are failing, the liver is failing. All of these things start to shut down. So you can't come back from this. What we want to do is recognize here, or in these early stages of compensatory shock, that now, we've got a patient who there's potentially something going on that we need to manage, aggressively. We'd much prefer to overtreat and prevent them from going into shock than waiting until they show these outward signs. By the time you see this, we're going to have a hard time managing and stabilizing this patient, right? So when we look at adults, because we have more reserves, adults compensate a little bit better. We kind of look at like that bell curve. So we have a bit more time. Children we've talked about, they don't have as much of a reserve system. So they compensate really well. And then what happens is they run through their sugar supply, their fuel supply, and now all of a sudden they drop off like a cliff. By the time we see a child who's bradycardic, this is a kid now we're concerned that we're going to start having to do CPR. Right? This is a kid that we're concerned that we're going to have to resuscitate. So we want to make sure that we're being aggressive in our management and preventing these things from progressing. Okay? So look this over. This is stuff you're going to see all over testing, and this is stuff when we look at in our patients, we're going to deal with this with every single patient we come in contact with. We have to be able to identify these life-threatening conditions and how to manage them.